Don't worry, don't worry. I will. So you keep noticing the node, huh?
You start. Good evening, everyone. Welcome to ISA National Online PG classes. These classes are held every Monday, and today's class will be on anesthetic considerations in a patient posted for ERCP. I am Dr. Ashita Rukmini, currently working as a senior resident in AIMS, Delhi, and I would be your screen coordinator for today. So before we proceed further, let us seek the blessings of Goddess Saraswati. Welcome. I would like
Ashita.
Yes, sir.
Thank you, Ashita. I will do it things.
Okay, sir.
So good evening, everyone. So this is the first class after the national conference. So starting of a new season again, and who better than our president sir gracing the occasion. So it is an honor for us. So I like Dr. Bala Venkat sir to speak a few words regarding this webinar and these classes. Bala Venkat sir.
Thank you so much to the Secretary, the dynamic Dr. Sukhminder Jit Singh Bajwa. Thanks for initiating the PG classes for this session. And I'm truly privileged to be a part of the first session, and especially the first session after I took over the responsibility of the National President of Indian Society of Anesthesiology. To all the young minds who are going to participate in this session as speakers and panelists, heartiest congratulations, because it's very important to communicate. You may know so many things, but it's important to communicate. And the art of communication comes from being a part of such sessions. It is in the process of holistically creating a pathway for you as a clinician, as a thinker, and as a speaker. So thank you very much for all of you. You're participating. And also my special thanks to the word that she used was beautiful, the screen coordinator, Dr. Yashita from All India Institute of Medical Science. The way you started, absolutely brilliant. And I wish you all the very best in your future endeavors. For all the young postgraduates, knowledge is power. The more you know, the more you are respected. The more you know, the more you apply. What the mind does not know, the eyes does not see. So it's important to equip yourself with as much as you can when you're a young postgraduate, because this is something not to pass your MD or DNB examination, but this is to pass the lesson for life of preventing anything that is happening for your patient when you are at the head end. I'm wishing you all the very best, and I'm sure this year this will go on very smoothly, covering several facets of perioperative care, of our patients. Thank you so much, Dr. Bajwa, for giving me this opportunity. And I'm sure the young minds will do their best to make it a very successful event. Thank you.
Thank you, sir. Thank you for your blessings, and I know your guidance will also help us in taking these classes to, I think, to the global level now. What we are planning to take these classes to different parts of the globe. So these classes will
Absolutely,
be
absolutely. I think in the future meetings we can have faculty moderating from US and UK and Europe. We'll do that.
yeah, definitely, sir. Definitely. Thank you, sir.
Thank you
Thank you very
so
much.
much.
Yeah,
Thank you. Thanks.
yeah.
And that's such a pleasure to be a part of this.
Thank you, sir. And importantly, we have today our GC members also, but we will listen from them in the last. They have to sit in the class to see how the classes are going, so that I can hear their comments at the end of the class from all the GC members who will be logging in today. And definitely coming to the topic, we should start the topic. So ERCP, I think yesterday we were talking about in Thane about the Nora, how the Nora is going to be taking place, what are the limitations, what are the, the precautions you should be taking to ensure the patient's safety while giving the or administering the anesthesia at these locations, especially when these patients are coming for this procedure. They are definitely having a comorbidities that those throws a different challenge altogether. The sedation part, the airway part, so many challenges are there. The topics, the surgical procedures, looks very simple. They're just like endoscopic, you're putting that something, but giving administering anesthesia itself a challenge in this situation. I know our PGs, they are well prepared today and they will be dealing with it, and they have good teachers to guide them, led by the Dr. Utkala Hegde ma'am. So I give it back to Dr. Ashita to kickstart the proceedings from here.
Thank you, Balavenkat sir and Sukhvinder sir for your kind words. Now, let's proceed the session. And now I would like to hand over the stage to my co-screen coordinator, Dr. Saili.
Good evening, everyone. I'm Dr. Saili, anesthetist from Nashik. I take immense pleasure in inviting and introducing the moderators for today's session. I would like to extend my warm welcome to Dr. Utkala Hegde Madam. She is professor and HOD in MVJ Medical College and RH, Bangalore. It is affiliated to Rajiv Gandhi University of Health Science, Karnataka. She has PG teaching experience of 20 years. She has special interest in difficult airway and obstetric anesthesia. She has total 11 publications, including national and international. I also extend my warm welcome to Dr. Shailesh Kumar. He is professor in MVJ Medical College in RH. He has PG teaching experience of 10 years. His special interest is in pain management. He has 5 national and 3 international journal publications. I would also like to extend my warm welcome to Dr. Rakesh K. He is assistant professor at MVJ Medical College in RH. He has PG teaching experience of 4 years. His special interest is in airway and pain management. He has 3 national and 2 international journal publications. So before we begin, I would like to tell the general rules for the audience. Kindly stay muted and turn your videos off. If you have any queries, kindly type in chat box. The questions will be addressed at the end of the session. Thank you for your cooperation. I now hand over the session to today's moderators to introduce their PGs and continue with the session. Thank you.
Good evening, I'm Dr. Rakesh, Assistant Professor from Department of Anaesthesia, MVJMC Bangalore. I would like to introduce my 2 PGs, Dr. Rutvik, a 3rd year postgraduate, and Dr. Trinath, 2nd year postgraduate.
Good evening, everyone. Myself, Dr. Rutvik, and I'm a final year postgraduate in MVJ Medical College.
Good evening, everyone. Myself, Dr. Trinath, 2nd year postgraduate from MVJ Medical College.
You should start now. Rutvik, you should start.
So I'll be talking about anesthetic considerations in ERCP. My moderators are Dr. Shailesh and Dr. Rakesh. So, as case presentation, patient name so and so, 68-year-old male who is a laborer by occupation, hailing from Maruti Extension, Kolar, belonging to lower middle class socioeconomic status. He came with chief complaints of yellowish discoloration of the skin and eyes since 6 months, loss of appetite and generalized weakness since 2 months, clay colored stools since 1 month, itching of the skin since 15 days, pain abdomen since 15 days, nausea and vomiting since 1 week. History of present illness. The patient was apparently normal 6 months ago, after which he noticed yellowish discoloration of the skin and eyes, which was insidious in onset, gradually progressive in intensity. There was no history of prodromal symptoms before the onset of jaundice. Patient also had history of generalized weakness and fatigability since 2 months. There was history of loss of appetite and weight loss since 2 months. There was history of 2 to 3 episodes of clay-colored stools per week past 1 month and history of itching of skin since 15 days. Nausea and vomiting since 1 week. Also, there were 1 to 2 episodes per day, which was non-projectile in nature. It contained food particles and non-bilious in nature. There was history of pain abdomen since 15 days. It was more in the right upper quadrant, severe in intensity, intermittent in nature, and non-radiating. It aggravated with consumption of fatty meals. There was no history of fever, chills, no history of abdominal distension, no history of decreased urine output, no history of altered sensorium, or no history suggestive of blood in stools. Past history, patient is not a known case of hypertension, ischemic heart disease, diabetes mellitus, tuberculosis, seizure disorder, or bronchial asthma. There was no history of similar complaints in the past, no history of medication intake, no history of previous surgery in the past, no history of blood or blood products transfusion, no history of recent traveling since past 1 year. Personal history, patient had a mixed diet, appetite was reduced, bladder habits were regular, bowel habits also regular, with the normal sleep pattern. Patient is a non-smoker, but occasionally consumes alcohol from past 15 years, approximately 30 to 60 ml twice weekly. Family history, there was no significant family history. Coming to general physical examination, the patient is conscious, oriented to time, place, and person, undernourished, height was 160 centimeters, weight of 45 kgs, the body mass index was 17.4 kg per meter square. Vital signs, pulse rate was 79 per minute, the rhythm was regular, a low volume pulse, there was no vessel wall thickening, there was no radioradial or radiofemoral delay. Blood pressure was 100 by 60 millimeters of mercury. It was measured in the left arm in sitting position. Saturation was 98% at room air. Respiratory rate was 16 cycles per minute. It was regular abdominothoracic type of breathing. Temperature was 98.4 degree Fahrenheit and METS was more than 4. General physical examination continue. Pallor was absent. Icterus was present over the sclera and skin over the chest, not noted over the palms and mucosa. Cyanosis absent. Clubbing absent. Generalized lymphadenopathy was absent. There was no pedal edema. Multiple scratch marks were noted over the abdomen and limbs. There were no signs of liver cell failure, no signs of tattoo marks on the skin or visible injection marking on the skin to rule out drug addiction. Airway examination. There were no loose teeth or dentures. Mouth opening was approximately 5 centimeters of breadth. Temporomandibular joint was subluxable. Thyromental distance approximately 6 centimeters of breadth. Modified Malampati was class 2. Neck movements, adequate flexion and extension. Upper lip bite test was class 1. Coming to systemic examination per abdomen. On inspection, the scaphoid in shape, the flanks were free, no visible pulsations. Umbilicus was central and inverted, no visible mass or stars noted. All quadrants of abdomen moves equally with respiration, and genitalia was normal. Palpation. The inspectory findings were confirmed on palpation. The abdomen was soft with no local rise of temperature, non-tender, no guarding or rigidity, no rebound tenderness. The liver was palpable just below the right subcostal margin with regular border, firm in consistency and moves with respiration. There was no splenomegaly. Percussion. A tympanic note was elicited in all the quadrants. No shifting dullness noted. The liver dullness was noted in the right fifth intercostal space in the mid-clavicular line. Auscultation, bowel sounds were heard. There was no venous hum or arterial bruit. Respiratory system, bilateral air entry was present. Normal vesicular breath sounds were heard. Cardiovascular system, S1, S2 heard. No murmurs. Central nervous system, higher mental functions were normal. There was no focal neurological deficits, and all cranial nerve examination was normal. So, impression, we have a 68-year-old elderly male with no known comorbidities presented with progressive yellowish discoloration of the skin, itching, loss of appetite, weight loss, clay colored stools with intermittent spasmodic type of pain, probably due to obstructive jaundice with no signs of liver cell failure. On investigations, the complete blood picture showed a hemoglobin of 14.3 grams per deciliter. Total counts 6,300 cells per cubic millimeter. Differential count, neutrophils 52%, lymphocytes 43%, eosinophils 4%, basophils 1%, and monocytes nil. Platelets was 2.25 lakhs per cubic millimeter of blood. Packed cell volume was 41.7%. Peripheral smear showed normocytic, normochromic blood picture. The prothrombin time was 14.1 seconds. Activated partial thromboplastin time was 26.7 seconds with an INR value of 1.12. Serum electrolytes, sodium was 135 milliequivalents per liter, potassium 4.5 milliequivalents per liter. Serology was done for HIV, HBsAg, and HCV. It was non-reactive. Renal function tests, blood urea of 20 milligram per deciliter, serum creatinine of 0.8 milligram per deciliter, serum uric acid was 3.2 milligram per deciliter. Liver function tests, total bilirubin was 4.8 milligram per deciliter, direct bilirubin 3.1 milligram per deciliter, indirect bilirubin 1.7 milligram per deciliter, SGOT 157 international units per liter, SGPT was 141 international units per liter, alkaline phosphatase 564 international units per liter, total proteins was 5.7 grams per deciliter, and albumin was 3.3 grams per deciliter. Investigations, the chest X-ray was within normal limits, and a 12-lead ECG showed normal sinus rhythm with normal axis. Ultrasound of the abdomen and pelvis, the hepatobiliary showed diffuse increase in parenchymal echogenicity. There were few, that is 2 to 3 echogenic foci, casting the posterior acoustic shadowing noted in the lumen of the gallbladder, the largest measuring approximately 8 to 6 millimeters in size, cholelithiasis, and grade 1 fatty liver. Magnetic resonance cholangiopancreatography, MRCP, was done. It showed multiple well-defined round to oval T2 hypointense foci in the gallbladder, the largest conglomerate measuring 17 into 7 millimeters, and two similar foci was noted in the cystic duct measuring 2 millimeters. A 9 into 6 millimeter sized conglomerate of T2 hypointense foci also noted in the common bile duct. Impression was cholelithiasis with choledocholithiasis. Final diagnosis was cholelithiasis with choledocholithiasis. So the pre-anesthetic evaluation was done. Once thorough investigations and history taking, the case was accepted under ASA physical status grade 2. The planned procedure was ERCP, that is endoscopic retrograde cholangiopancreatography. It was planned under general anesthesia with endotracheal intubation with intermittent positive pressure ventilation. Preoperative instructions. The patient was advised for NPO for 6 to 8 hours for solids, 2 hours for clear liquids. Informed and written consent was taken. An 18 gauge IV cannula was secured on the dorsum of the left hand. An injection xylocaine test dose was given. And as per the gastroenterologist advice, bowel preparation was done using the coloprep kit. Patient was shifted to the operating theatre after checking the anesthesia workstation, suction apparatus, crash cart with emergency drugs, and then connected to standard ASM monitors. Baseline vitals were recorded with non-invasive blood pressure, ECG, capnography, oxygen saturation, and temperature. Intraoperative, on the patient trolley, the patient was pre-oxygenated with 100% oxygen for 3 minutes. The patient was pre-medicated with injection glycopyrrolate 0.01 mg per kg I intravenous, injection midazolam 0.01 mg per kg IV, injection fentanyl 2 microgram per kg IV, and patient was induced with injection propofol 2 milligram per kg IV, and patient was relaxed with injection succinylcholine 1.5 milligram per kg IV. And under direct laryngoscopy, the patient was intubated with an 8 millimeter internal diameter cuffed endotracheal tube and was fixed at 21 centimeters after confirming bilateral equal air entry. Injection atracurium 0.5 milligram per kg IV was given. The patient was later shifted onto the operating table to prone position. Patient was maintained on oxygen, nitrous oxide, isoflurane, and injection atracurium 0.2 mg per kg IV top-ups. Intraoperative vitals were stable. The intraoperative findings were selective common bile duct cannulation was done. The cholangiogram showed multiple filling defects over the distal common bile duct, smooth tapping of the lower common bile duct stones extracted with balloon sweeping. The biliary stenting was done and stent draining clear bile. Patient withstood the procedure well. So ERCP with biliary clearance and biliary stenting was done. Once the procedure was done, the patient was turned to supine position, and after noticing spontaneous breathing efforts, thorough oral suctioning done, and the patient was reversed with injection neostigmine 0.05 mg per kg IV along with injection glycopyrrolate 0.01 mg per kg IV. Once the extubation criteria was met, the patient was extubated and connected to a simple face mask at 4 liters per minute oxygen. There was no desaturation and no tachypnea noted. Post extubation, the patient was monitored for 15 minutes inside the OT and later shifted to the post anesthesia care unit. Post-operative analgesia was given by with injection diclofenac 75 milligrams intramuscularly.
Okay. Rutvik, come back to the first slide, history. Okay. Shailesh, your voice is muted. Okay. Yeah. So, you say there is yellowish discoloration of skin and eyes in 6 months, and is a
Yes,
68-year-old male patient and is a laborer. So, how do you differentiate the muddy sclera from yellowish discoloration of skin and eyes?
sir, we can differentiate muddy sclera with jaundice by looking at other sites also, sir. If in
Okay.
case of jaundice, we can also look for the undersurface of the tongue and
Mm.
also the nail beds, the palms and soles. Also, we can find the signs of victories, sir.
Acha. So, why do you think only you will see for sclera or like nail beds for looking at yellow discoloration? Why is that so?
Sir, in sclera, there is elastin, so
Hmm.
which has got high affinity for bilirubin. So, on natural light, it can easily be elicited. And also in the palms and soles, we can notice once the bilirubin levels are much higher, sir.
Good. So, the affinity for bilirubin for elastin is more. So, only you can see in the sclera and right. Okay. Shailesh, anything to be added?
Yeah, correct. So I agreed with Ritvik. Oh, there's a pain abdomen since 15 days. So we'll just go to the history of presenting illness, Ritvik. Yeah. So you have mentioned what is nature of pain? Beginning, starting time?
The pain was more in the right upper quadrant, severe in intensity, intermittent and non-radiating type.
Okay. So this kind of pain is. Can you tell about the DD of this kind of pain in upper quadrant pain? Like,
So, right upper quadrant pain, usually we can think of biliary pain, also acute cholecystitis, or even duodenal ulcers. It can be hepatic abscess, or even sometimes acute MI, and also rarely even GERD, that is gastroesophageal reflux disease, and yeah, hepatitis pain also can be seen.
yeah, good. Uh,
And you are telling about vomiting, like you can see contained food particles and non-bilious. Can you just quote an example for other types of vomiting, like content of vomitus?
Where if it is projectile in nature, if it can be raised ICP, contained blood, we can rule out GI bleeding, or it can be Mallory Weiss tear,
Mhm. Okay, any gastric outlet obstruction?
gastric outlet obstructions.
Okay, fine. So usually the carcinomatous things like gastric carcinoma will also lead to like foul smelling vomiting. Okay,
No.
is that fine? So okay, next. Okay, why did you ask history of decreased urine output?
urine out.
Sir, sometimes the patient might be in hepatorenal syndrome, which is one of the complications of final end stage renal liver disease. So if
Mhm.
the kidney is involved or not, so we can easily come to know by asking the urine outputs.
Okay, good. Altered sensorium.
Altered sensorium to rule out metabolic encephalopathy, sir.
Hmm. Okay.
Okay.
And coming to fever and chills.
Prodromal symptoms of liver disease, such as fever, chills, arthralgia, and malaise.
Hmm.
So, to rule out all the prodromal symptoms, I had to ask all this.
Okay, good. You can other DDs as you mentioned, abscess and okay, cholecystitis, acute cholecystitis and all. So we can see fever in okay abscess and acute cholecystitis, right? So we can rule out those things. Good. Have you come across like what are the effects of this bilirubin and bile salts or bile things on the cardiovascular system?
Sir, excess bilirubin, it has got negative inotropic and chronotropic effect on the heart. Also, there will be bradyarrhythmias. The pulse rate will be lower side because of deposition of the bile salts on the conducting system, particularly the SA node.
Hmm.
So it is called as jaundiced heart.
Okay, you would have ruled out those things also. Okay, you can ask negatives pertaining to these also.
Ritik, it's a full conducting system. Okay,
Okay.
more on the SA node actually.
So any syncope or something like that, you can just ask. Okay, even though it's at a fulminant, but still you can cover it, right? Okay. Next.
Next slide.
So yellowish discoloration of sclera, any medicine can mimic it?
Your isoniazid, rifampicin, drugs which can cause cholestasis.
Okay. Okay. Some more drugs like quinacrine therapy can also mimic it, right?
Quinacrine therapy.
Yeah, good. Yeah, okay. Next slide.
What is the significance of this blood transfusion? Ritik?
Sir, sometimes there might be transfusion of incompatible blood. So that time hemolysis may occur and it can point out towards jaundice.
Yeah, that is there. And anything, chances of this one transmission through blood, viral hepatitis kind of, that also can cause jaundice. Okay,
Infections with contaminated blood are also chances which might cause hepatitis.
yeah. So what are the transmission through blood? What were how many type of virus are transmitted through blood?
Hepatitis B virus is most common. Superimposed hepatitis D virus also sometimes.
Yes. Okay. And any cytomegalovirus, anything?
Cytomegalovirus and Epstein-Barr virus also sometimes.
So hepatitis B virus is RNA virus or DNA virus?
Hepatitis B is a DNA virus, sir.
Yeah. Good. And, fine. So your patient has a comorbidity like IHD, diabetes. They are free from these all comorbidities.
No, sir. The patient has no known comorbidities.
Fine. Go to the next slide. So what kind of alcohol is consuming, no? So what is since 15 years, what is significance on this one, liver?
Sir, there is a weekly safety limit for consumption of alcohol. So if it exceeds that, patient might go into alcoholic liver disease.
ALD. So he is taking approximately 30 to 60 ml twice weekly. So, but what kind of alcohol he is taking?
The patient was consuming whiskey, sir.
Whiskey. So what is percentage of alcohol in that one?
Approximately 40 to 45% of alcohol is present.
Okay, so that is also important, no? Percentage of alcohol, what kind of he is taking. Okay, fine. So agreed. Go to the next slide. Okay, so there is no family history, nothing significant. Fine. Go to the next slide. Okay. Fine. So pulse rate is 79. So, pulse rate is 79 and blood pressure is 100/60. Fine. So there is a hyperbilirubinemia. So what Dr. Rakesh has mentioned before also, what are the effect of bile salt on that one? So this patient is not looking like any effect is there on that conducting system. Okay.
Yes.
Oh,
There is no bradycardia noted.
Yeah. So what kind of bradycardia is there? What kind of bradycardia in especially liver failure, this one, hyperbilirubinemia patients? So it will respond to drugs or it's a partial, it's a normal response with the drugs or partial response with the drugs?
So there will be blunted responses to the drugs, especially
Because
the beta adrenergic response.
correct. Refractory kind of. Okay.
Refractory kind of.
Fine. Okay. Go to
Hello,
the next.
Rutvik. Can you please tell me something about this sleep pattern in these liver failure patients?
These patients usually, if they're in metabolic encephalopathy, they might have altered sleep cycle.
Okay. So, altered sleep in the sense they'll be having excessive daytime sleepiness, or they'll be having the biological rhythm will be altered.
Nighttime they'll be awake, sir, and daytime there will be excessive sleepiness in them.
Okay,
The
fine.
circadian rhythm is disturbed.
Okay, good. Next. Go to the next slide. So, why did you ask generalized lymphadenopathy in this patient?
So sometimes to rule out if there are any enlarged lymph nodes, because in certain GI malignancies, gastrointestinal malignancies, the left supraclavicular lymph node may be enlarged. Also, the lymph nodes around the umbilicals also might be palpable in certain carcinomas. To rule out, I had to ask for generalized or certain lymphadenopathies.
Okay. See, when a patient walks into your clinic, how do you examine examine for icterus in that patient?
Icterus has to be ideally examined under natural light. So we have to place the patient next to the window, and under natural light, we have to examine for presence of jaundice.
Yeah, that's good. Actually, we should not do it under artificial light. Okay.
Okay. Ritvik, icterus you said here present over sclera and skin over the chest. Okay. So can you define the grading of icterus?
Sir, icterus, if the bilirubin level is more than 3 milligram per deciliter, it is usually seen on the sclera. On the face, it is usually 4 to 8 milligrams per deciliter.
Yeah.
And if it is over the upper trunk, it is 8 to 12 milligram per deciliter. And lower trunk, abdomen, and thighs, the bilirubin levels are usually 12 to 15 or 12 to 16 milligram per deciliter. And over the palms and soles, the bilirubin values will be more than 15, sir, usually.
Good. So our up to chest, you notice this one is icterus is there. You have mentioned how much bilirubin there in your investigation?
So my patient had a bilirubin of 4.8, 4.8 milligram per deciliter.
It's near about 5. So that's why. Okay, good. Matching. And go back to
Come back to general physical examination.
Examinations.
Okay. Why pedal edema? Any significance in these patients?
In patients with chronic liver disease, where albumin might be reduced, so it might cause generalized swelling, which initially seen as pedal edema.
Okay. So you mentioned no signs of liver cell failure. From head to toe, can you tell me what are the signs of this liver failure?
It is alopecia, xanthomas, bilateral parotid gland enlargements, fetor hepaticus, loss of axillary and pubic hair,
What is fetor hepaticus?
gynecomastia, fetor hepaticus.
Mhm.
There is also palmar erythema, Dupuytren's contracture, testicular atrophy, and also asterixis is noted, flapping tremors.
Okay, good. So how do you elicit for these flapping tremors?
We ask the patient to outstretch both the upper limbs and extend the wrist and observe, sir. If the flapping tremors are present, there will be gradual drop in the wrist.
There'll be flapping like this, right?
Yes.
There'll be flapping tremors. Okay. There'll be decreased sexual drive also for these patients. Okay.
Loss
Next,
of libido.
loss of libido. Yeah. See, when you're examining airway for a patient posted for ERCP, so what are most important points to be highlighted?
One is the presence of any artificial dentures or any loose teeth. And
So,
second
see,
is
basically, we are now discussing something related to ERCP. So, in that terminologies, just relate me, like, what are like importance of your airway examination? Why
one is
you want to
mouth
look for these teeth and dentures?
because sometimes when we pass the endoscope, there might any loose teeth can be damaged and it can cause aspiration, sir.
Mhm. Okay.
Second is mouth opening and modified Mallampati class,
Okay.
and also neck movements. Range of motion is actually important for us
Why is it
because
important?
ERCP procedures usually can be done under both general anesthesia and deep sedation. So that is if the airway is compromised at any point of time during the procedure under sedation, then we might have to intervene to protect the airway. So that is why the Mallampati and mouth opening comes into importance.
No, from the gastroenterologist point of view, why neck movements are important?
The positioning during the procedures.
Neck while passing the endoscope. So,
Into
it is important for us.
Ritvika, this neck movement you mentioned, neck circumference is important for airway examination.
Neck circumference is important.
Yeah, so
In
you mentioned neck.
patients and in a patient with obstructive sleep apnea, where
Yeah.
there might be difficult airway.
Correct. So what is upper lip bite test and classes? How you will mention? How you will classify that one? Upper lip bite test.
The upper lip bite test, it is very specific and sensitive for predicting difficult airway. So class 1 is when the patient is able to bite the upper lip beyond the vermilion line. And class 2 is patient is able to bite the upper lip just below the vermilion line. And class 3 is patient is not able to extend or touch the upper lips.
Yeah, this is very important parameters. So if even you will not get many things in this upper whatever mentioned is there. No, upper lip bite test will tell about difficult airway very easily. Okay, next slide.
So you mentioned inspection of this patient per abdomen. So what are other things when you see when there is a fulminant liver failure in inspection? What all you look?
We can also look for caput medusa, spider nevi, any pulsating, visible pulsations, sir.
And there may be distant
Fulminant
abdomen.
hepatic failure, they might have tense ascites, so the flanks might not be free in that conditions.
Okay. Okay. Good that you mentioned genitalia. Always you should examine genitalia when you're. Okay, good. Anything to add it, sir? Shall I, sir?
That's good. We'll go move to the next slide.
So, coming to this examination of liver, you have written as palpable just below the right subcostal margin, regular border, firm in consistency. Can you please tell us regarding the various other consistencies and the diseases pertaining to that?
Sir, in case of cirrhosis, it might be hard.
No, it should not be, it might be. It will be like,
It will be hard.
okay, what
It will
about
be
in
hard.
carcinoma?
Carcinoma, and it will be shrunken, sir. The liver might be enlarged or shrunken.
No, not
It
necessarily it should be shrunken all the time, right? In carcinoma, why should it be shrunken? It will be irregular and enlarged only, right? It will
regular
be
and
regular.
rubbery.
Border will be regular. Okay. What about what will the consistency in congestion? Right heart failure?
Will again be firm and
Yeah, but borders will be smooth.
Borders will be small.
Firm consistency, border will be smooth, but liver will be enlarged. So by palpation, we
enlarged.
can to some extent we can make the probable diagnosis, right?
Yes, sir.
Okay. So why do you want to like look for spleen? Is any relation between spleen and liver?
In certain conditions where there can be hepatosplenomegaly together coexisting. Suppose in
Okay.
case of excess hemolysis, the spleen will be enlarged. So
Yeah, hyperspleen.
splenomegaly will also be present.
Okay. There will be breakdown again. It can cause jaundice in turn, right?
Joints.
Okay. Oh, good. Next.
Oh, next slide.
So, what is the difference between fluid thrill and shifting dullness?
So fluid shifting dullness is noted when there is 1 to 2 liters of ascitic fluid, but fluid thrill is noted when there is beyond 2 liters of ascitic fluid presence.
No, not beyond 2 liters. The abdomen should be tense when you do a elicit sign of fluid thrill. So abdomen should be
The
tense. All the
abdomen
flanks should be filled. Then only will the whatever thrill you will be
fluid
transmitted,
thrill.
right? So there should be tense ascites. Okay, for shifting dullness, as you said, 1 or 2 liters sufficient. But whereas for fluid thrill, the ascites should be tense. Okay. Okay, next slide. Sir, anything to add?
No, I will go to next
Yeah,
slide.
next.
Yeah.
So your diagnosis is 68-year-old male patient with no known comorbidities presented with progressive yellowish discoloration of skin, itching and loss of appetite with weight loss. So weight loss. When you say there is, how do you define the significant weight loss?
Your effective weight loss is when there is more than 5% of the body weight lost in 3 months, or
Mhm.
more than 10% of the total body weight is lost in 6 months duration. Sir.
Okay.
Beyond that is called effective weight loss.
Mhm. Why will this patient have clay-colored stools?
Sir, in obstructive jaundice, there will be obstruction to the outflow of bile. So the bile cannot be drained into the intestines. So it will be reflux back into the circulation. So since there is no conjugated bilirubin in the bile, it cannot be converted to stercobilin, which imparts color to the stools.
Okay. Uh, so can you briefly tell us regarding this bilirubin metabolism, very briefly?
Once the senescent RBCs, like after 120 days of their lifespan, they are lysed by the reticuloendothelial system. So hemoglobin is broken down into heme and globin. So the globin part is again reabsorbed by the liver, and the heme is converted to biliverdin with the help of the enzyme heme oxygenase, and biliverdin is again converted to bilirubin by biliverdin reductase. So this unconjugated bilirubin is lipid soluble. So this is carried along with albumin to enter the liver, and in the liver undergoes conjugation with the UDP glucuronide transferase enzyme. So once it is conjugated, it then is excreted from the liver into the biliary system into the intestines. So once this conjugated bilirubin enters the intestine, it is converted to stercobilin acted upon by bacterial enzymes. So it gives stercobilin, which gives stool its color. Also, 10% of the bilirubin undergoes interhepatic circulation, which forms urobilin, giving urine its characteristic yellowish color.
Good.
Okay.
Okay. So as per now, your diagnosis is this. So what about go to next slide.
Okay. Investigation part. Next slide. Okay.
So why coagulation profile is important in liver failure patients or any pathology in the liver?
Liver is involved in synthesis of coagulation factors. So that is why if the liver function is impaired, there might be deficiency of coagulation factors.
Okay. What are
Also,
vitamin? Huh? What are the vitamins? Fat soluble vitamins?
vitamin A, D, E, and K. These are
Okay,
the
that
four fat soluble vitamins synthesized.
okay. Is there any significance for our case and fat soluble vitamins?
Sir, vitamin K, there are certain factors 2, 7, 9, and 10. They are vitamin K dependent factors. So, since there is no bile for the absorption of vitamin K, so
Not only vitamin K. Okay, yeah, good. Yeah, please go on.
all these coagulation factors will not be synthesized. So, it can lead to bleeding tendencies and coagulation disorders.
Okay. Also, because of this, the fat soluble vitamins absorption will also be hampered because there will be fat intolerance in this patient, right? So only. Okay.
So, Ritvika, can you tell me which is more important coagulation parameter in this obstructive jaundice patient or liver failure patient, PT or APTT?
Sir, it is prothrombin time, sir.
Prothrombin time. Why?
Because the extrinsic pathway where factors 2, 5, 7, and 10 are involved. So factor 7 is deficient in liver failure. So more prothrombin time is usually prolonged in case of patient with liver disease.
Liver disease. Good. Okay. Go to next slide.
Next. His renal functions are normal. Okay. Go to next slide. So coming to this enzyme part, which is more specific to liver.
SGPT is more specific, sir.
Okay. So when do you say that it's elevated?
When it is more than 3 to 5 times the normal value, we say it is elevated.
Okay, good. Okay. What about this alkaline phosphatase?
Alkaline phosphatase, if the level is beyond 300 international units per liter, then it is considered significant.
What are the other specific enzyme for obstructive liver disease to see for?
Sir, we can see GGT, that is gamma glutaryl transferase, and also 5' nucleotidase.
Can
These
you tell about the
also are
normal level of GGT and nucleotidase?
the GGT normal level is around less than 70, sir, usually. And 5' nucleotidase is around 5 to 10.
Okay. And
So
among GGT and 5' nucleotidase, which one will tell about the chronic liver conditions more?
Sir, it is 5' nucleotidase.
Yeah, it is elevated in chronic liver failure.
what about in alcohol abuse? Which are the enzymes that will be elevated?
In alcoholic patient, there will be AST, which is elevated more than ALT. The
Okay.
ratio is usually more than 2:1 or 3:1. Along with that, GGT is also persistently elevated.
Okay. In hepatobiliary, like in obstruction, as you discussed, again 5' nucleotides will be elevated. Okay.
Okay.
So next slide.
Just
Coming to ECG, do you find any
go back to
important things in ECG?
Here, the patient did not have any bradyarrhythmias.
Okay.
No, there was no conduction blocks noted also.
Okay. Fine. Okay. USG, you saw so many. These are the findings. Next. Okay. Now tell me, what are the advantages of this MRCP? Why did you undergo like MRCP? Why was it done?
MRCP, sir, the MRCP is non-invasive procedure, sir.
Okay.
ERCP is invasive procedure.
Mm-hmm.
MRCP does not require any ionizing radiation.
Mhm.
Now, why did you do in this patient MRCP?
For diagnostic purpose, sir.
So you'll exactly know where exactly you have these blockages and all. Okay, we'll have entire picture of this hepatobiliary system, right?
Yes, sir.
So then we can go ahead. We have exact blueprint where exactly the stones are there and how can we deal with it, what are the exact sizes and all, right? Okay. So it's cholelithiasis with choledocholithiasis. Okay. Next. So now what do you want to do? How do you want, like next, what do you want to do with this patient?
So next we can since the patient had cholelithiasis with choledocholithiasis, the patient was planned for ERCP procedures.
Okay.
Okay.
So if you deal with only choledocholithiasis, look, like for example, your gastroenterologist was planned for this choledocholithiasis. Okay. So what about the stone in the gallbladder? Again, it can recur, no? Symptom. Again, the patient can present to you with the similar complaints.
Yes, sir.
So there is something concomitantly we can do this cholecystectomy followed by ERCP. Understood?
ERCP.
Yeah. Okay. Now you are
Correct.
posting this for ERCP. Okay. Go ahead.
So once the pre-anesthetic evaluation was
Yeah,
done,
this is
we
Mhm.
admitted the case under ASA physical status grade 2 and he was planned for ERCP. The anesthetic
Why
plan was
ASA2? Why ASA2?
the patient is a known alcoholic, sir. So ASA status was grade class 2.
Hmm.
So you are planning ERCP under general anesthesia.
Yes, sir.
Okay. So that we'll discuss in the discussion part. Next.
Hmm.
What is this coloprep kit?
Sir, Poloprep kit is osmotic laxative which contains magnesium sulfate, potassium sulfate, and sodium sulfate, along with that polyethylene glycol. So it is used to prepare the bowel prior to the endoscopic procedure, sir.
Okay. Okay. Good. Shall I say anything to be added?
Yeah.
Better
So,
visualization of the bowel.
so why you want to give Jalocan test dose for this patient?
Sir, sometimes patient might have anaphylactic reactions to the local anesthetic, that is xylocaine,
Correct.
because it is used in almost all the procedures. So to rule out anaphylaxis or allergic reaction to we administer a xylocaine test dose.
Okay. Because you are using Jalocan in any form in this patient? ERCP
Sir, we are
procedure patient
using
endoscope.
Xylocaine mouth spray.
Yeah, mouth spray you will use. Okay. So what are the other very important agent what is used in this procedure which can cause anaphylaxis?
Sir, we can the dyes which is
Yeah.
used for cholangiogram. They also have risk for allergic reactions.
Or what are the content of that fluoroscopic dye?
So they are more usually iodinated dyes, sir. Indocyanin green most commonly is used.
Okay, so that's why you need to rule out that the patient has a local anesthesia, any anaphylaxis toxicity is there, to give test dose before only. Okay.
Yes.
If anaphylaxis will happen and you have not given test dose, you will not able to make out what are the causative agents, either it is a local anesthetic or it is a fluoroscopic dye. Okay. Fine. Then. Okay.
Yeah.
And,
Go ahead.
Ritvika, you have mentioned somewhere you are using succinylcholine. So according to this one, why you are using this one? Any RSI is required for this patient, or it is a
No,
protocol?
sir. Usually succinylcholine, before administering succinylcholine, we confirm whether the patient belongs to Vaishya caste or not. Because
Did you
they might
ask
have
in?
deficiency.
Did you ask in that PSC? Because you have not
Yes, sir.
mentioned anywhere. Okay, that.
It was asked during
Okay.
PSC.
Fine. So that patient is not Vaishya, then you can just decided to use.
Succinylcholine.
What is dose for RSI succinylcholine?
Sir,
Because
2
you used here
milligram
1.5. 1.5. Is it adequate dose? And
sir, ED95 for succinylcholine is 1 to 1.5 milligram per kg body weight.
okay. Fine. So if you will use 1.5 milligram per kg, so what is your duration to achieve the intubation condition, full relaxation?
45 seconds to 1 minute, sir.
1 minute. Okay. Fine. So because why I'm telling, no, 2 milligram per kg is ideal RSI dose, where 30 to 45 minutes you can get an ideal condition to intubate the patients. Fine. So good. Wait for the next fentanyl you are using here. Okay.
Yeah. Go ahead. Okay. Next.
Okay. Before anesthesia part, tell me what monitor you will attach.
Sir, non-invasive blood pressure, saturation probe, pulse oximetry, capnography, and temperature probes.
Temperature probes. Okay. So, and what is very most important monitor here?
Capnography, sir.
All are important monitor only, but I'm just asking for sake of just to check about the proper ventilation, capnography. That is very important. So this general anesthesia we are using here in our center. But what are the other anesthesia you can select for this patient?
So we can do this procedure under monitored anesthesia care and also TIVA, sir, total intravenous anesthesia.
Total intravenous. So can you tell about the duration of surgery in our center? How much it is going nearly?
Sir, in our centers, the procedure usually takes about 45 minutes to 1 hour.
Okay. Nearly 1.5 hour, nearly 1 to 1.5 hours.
Yeah.
So you are feeling like it is better to secure airway and go ahead with the GA. Okay.
Yes.
So, but the high volume center, what GA they are preferring more, or what MAC they are preferring more? Deep sedation or MAC?
High volume centers, they usually prefer to do the procedure under monitored anesthesia care.
Okay. So, what positions usually very important for this? So for what is position for that gastroenterologist according to them? What position is very preferred?
Sir, most commonly they use prone position. Along with that, they can use semi-prone, that is left lateral decubitus position, and supine position also. They are sometimes are used.
Okay, tell me about the advantage of prone position.
So in prone position, there is easy visualization of the biliary radicals.
Cannulation, easy cannulation, you are saying.
Easy cannulation.
Okay, okay. And for anesthesia prospect, what are the challenges in prone position?
So in prone position, first thing is there is airway compromise. So if there is any airway compromise, it will be difficult for the anesthesiologist to intervene. Also, the respiratory and cardiovascular compromise will be more.
And mechanical
Respiratory
obstruction chances, huh?
obstruction chances.
Mechanical obstruction of tube, kinking, these are the chances your patient, or displacement of tube. It is very high as compared to supine or other positions. Fine. So, but if monitored anesthesia care you are doing, and you are putting patient into prone positions, so what precaution you will take and how you will prepare your this one, anesthesia card? What you will do?
To put the patient in prone position, first I would like to intubate the patient in supine position on the patient trolley, and later shift the patient onto the operating the table on the prone position. So for this, I will need manual support, sir. So I'll need 3 to 4 members to position the patient accurately. And before that, in prone position, I'll be needing the bolsters and other paddings for the pressure points.
Okay, that care you will take. Anything you will put, any airway device that is good and that can just alleviate your this obstruction during procedures. Airway should be patent. No? Any nasal airway kind of things you will use. You are preferring here.
Sir, nasal airway can be inserted to keep the airway patent.
In case of monitored anesthesia care, I'm asking. Okay. So, what can you do if nasal airway? Can you this one take some circuit, vein circuit, and connect to the nasal airway?
Yes, sir. We can take the vein circuit and connect it to the nasal airway, and we can watch for the spontaneous breathing or respiration with the reservoir bag.
Reservoir bag. Okay. If any obstruction is there, then what you will do? What you will see? Where you will see? Any obstruction is there?
In capnography, we can
okay.
We can see.
Okay. Then if hypoxia, that another things, no, saturation will go down. Then what you will do immediately if you will notice hypoxia is happening?
So first thing is I would like to give 100% oxygen. Okay. And second is immediately stop the procedure, and then see for any obstruction.
No, endoscope is already inside. No, if there is a hypoxia, what you will do? If capnography is not coming and hypoxia is there, what you will do immediately? You will try to do something. No?
Connection or leaks. Check for any disconnection, leaks, or kinking of the tube.
First check. No, tube. I'm not asking. I'm asking monitored anesthesia care. Your patient is in prone positions. Okay, nasal airway is there inside, and even after that,
you provide 100% oxygen.
No, any maneuver you will do, just jaw thrust kind of any maneuver so
Chin
that
lift and jaw thrust position.
Correct. If a patient is gaining their airway control again, and saturation is picking up, okay for you. If it is not, then further. Correct. So, Dr. Rakesh, anything you want to add up?
Yeah, just I want to enter the class with few MCQs actually. So I'll share few MCQs.
Fine.
Okay. So, Rutvik and Trinath, I'm audible? Am I audible?
Yes.
Yeah. So coming to this MCQ, in obstructive liver disease, which one of the following tests of liver function likely remains normal? So option A is AST and ALT. Option B is alkaline phosphatase. Option C is albumin. Option D is 5' nucleotidase. And option E is gamma glutamyl transpeptidase.
Uh, it's option C, albumin, sir.
Okay. Why do you think option C, albumin, is the right answer?
So in obstructive liver disease, it is albumin is usually normal,
Okay.
whereas if there is hepatic jaundice or hepatocellular disease, where the function of the liver is uh, deranged, the albumin level usually comes down.
Okay. Ma'am is raising hand like.
Yeah, Dr. Rakesh,
Yeah, ma'am.
you have to give time for the audience to give the answers in the chat box.
Okay, sure, ma'am. Sure, ma'am.
Dr. Trinath can answer later
Yeah, sorry.
after
Sure.
you give chance to the audience to answer. Huh?
Yeah.
Okay, please carry on.
So can we move on to second question?
Yes, please.
Yeah. So which one of the following enzymes is found primarily in the liver? Primarily, like more specific to liver. Option A is AST. Option B is ALT. Option C is alkaline phosphatase. Option D is 5' nucleotidase. And option E is gamma glutyl transpeptidase. Which one of the following enzymes is more specific to liver or found primarily in the liver?
Alanine transferase, sir. ALT.
Right. Shall we move on to the next question, ma'am? Yeah, coming to the next question.
Yes.
Which one of the hepatitis virus is a DNA virus? Trinath, give us few seconds, okay? Let's all the audience see the question and answer. Option A is hepatitis A, B is hepatitis B virus, C is hepatitis C virus, D is hepatitis E virus, and E is HGV virus. Which one of the following virus is a DNA virus?
It is B virus, sir.
Okay, good. It is hepatitis B virus. So moving on to the next question. See, now we have posted this patient for ERCP. So what are the see, all of these are indications of ERCP. Indications for ERCP are all, but option is pancreatitis, option B is persistently elevated electrolytes, option C biliary obstruction, option D is jaundice. What indication for ERCP are all, but pancreatitis, persistently elevated electrolytes, biliary obstruction, jaundice. And what is the right answer according to you, Trinath?
Persistently elevated electrolytes, sir.
Okay,
Yeah,
good,
correct.
good. Yeah. We'll continue with the class and the rest of the MCQs I'll ask in between the discussion. Is that okay?
Yes.
So, Trinath, do you have any video related to this ERCP?
Sir. I would like to play the video, sir.
Yeah, please show us. Audio is not heard, Trinath.
Camera we called an endoscope. The endoscope.
Okay.
Done with a special camera we called an endoscope. The endoscope carefully guided down the esophagus. It goes through your stomach and small directed going to we need to take some tissue samples. The bile duct which is not working properly can be opened. If you have gallstones, they can be removed. Of the case, a mouth tube used to protect be inserted into the mouth. Pass through the of papilla to gain an access to the bile. Fluoroscopy, which is combination of an X-ray machine diagram.
So when there is difficulty in removing the stone, they are doing sphincterotomy. So the removal of stone becomes easy. Somehow the audio of the video played is not so clear. So yeah, when the balloon is passed, retrieval balloon, the stone is passed. If there is difficulty,
The back
they
for
do
an
sphincterotomy.
access.
If there is any a stricture and all, they do this stenting. So there'll be easy pass of this bile. The same way in the bile ducts. The stents are placed, so there'll be easy passing of the bile and hence obstruction is relieved. Okay. Trinath, what are the indications of ERCP?
So there are the indications are categorized into two ways, sir. One is diagnostic indications, another one is therapeutic indications. When it comes to diagnostic indications, narrowed or blocked bile or pancreatic ducts, tumors of gallbladder or pancreas, gallstones blocking the bile ducts, inflammation due to trauma or illness such as pancreatitis, sphincterophore dysfunction and biliary manometry, pseudocyst of pancreas, accumulation of fluid and tissue debris, scarring of bile ducts. These are the diagnostic indications for ERCP. And comes to therapeutic indications, removal of gallstones, sphincterotomy, stent placement, balloon dilation, tissue sampling, post-operative complications such as bile leaks or biliary strictures, patients with pancreatitis and cholangitis requiring emergency drainage.
Okay. See, coming to this diagnostic part of ERCP, MRCP is more advanced and it's non-invasive, right? Like any patient who has where we can't do ERCP is contraindicated. Definitely, we can go for MRCP. What are the advantages of MRCP as you were showing previously?
It is non-invasive procedure, sir, and it's only diagnostic procedure, not therapeutic procedure, and there is no risk of ionizing radiation and no post-procedure complications.
Yeah,
These are
very
the
good.
advantages.
Mhm. Yeah, good. So these are like disadvantages of ERCP. So what is the contraindications of ERCP? When ERCP is contraindicated?
Uh, the contraindications of ERCP if the patient is having unstable cardiopulmonary status, neurological disorders, and existing bowel perforation, structural abnormalities of esophagus, stomach, and small intestine, altered surgical anatomy, ERCP with sphincterotomy or ampulectomy in coagulopathy patients, and acute pancreatitis patients, and patients who are um, sensitive to iodinated contrastants.
Okay. Dr. Trinath, do you feel that ERCP should always be done in operation theater or the OR?
No, sir. In high volume centers, the ERCP is mostly done in the fluoroscopic procedure rooms with compact layout. In low volume centers, it is done in radiology suite or in the operating room using portable CM fluoroscopy. In low resource centers, mostly perform under general anesthesia with endotracheal intubation. In our institution, we perform in operating room under general anesthesia with endotracheal intubation.
Rutik, what is NORA?
So NORA stands for non-operating room anesthesia, sir.
Okay. Good.
Okay.
In your have you done any other things apart from this ERCP? What are the things you do under NORA in your institute?
For MRI, for sedation also we do it under NORA, sir.
Okay. Other like upper GI endoscopy?
For GI bronchoscopy and upper GI endoscopy, also we perform under NORA in our institution, sir.
It's just a MAC, okay? Okay.
And lower GI endoscopy also is performed under
Yeah.
NORA.
Okay. As sir discussed earlier, how do you prepare a patient for ERCP? How do you properly prepare a patient for ERCP?
Sir, for the ERCP procedure, the upper GI tract must be empty, nil per oral for 8 hours prior to the ERCP. Bowel preparation done with the coloprep kit, removal of dentures, jewelry, and contact lens. Smoking and chewing gum or chewing tobacco are prohibited during the nil per oral duration, sir.
Okay. Good. So,
Yeah.
yes, sir. Shailesh, sir, anything to be added?
Okay, so he mentioned bubble preparations, everything. Okay, Trinatha, that what Dr. Rakesh was asking, no, ERCP you are doing, and what are the other endoscopic surgeries? So you have mentioned everything. What we are doing in our institute, our center, can you tell about that?
In our institution, we perform the ERCP under general anesthesia with endotracheal intubation, sir.
Okay, okay, fine.
As the duration is 1 to 1.5 hour.
Fine. So we discussed this
securing
one. Just wanted to know about the lateral positions and what are the advantage and disadvantage of lateral and supine positions, and what patient you will select in that positions. Okay.
So Trinath, what are the as sir is asking, what are these advantages and disadvantages of this position? To start with prone position.
in prone position, most common position for the ERCP is prone position, as it allows optimal visualization and access to the endoscopic structures. In conscious patients, it requires cooperation of patient who can lie on their abdomen for 5 to 10 minutes until adequate sensation achieved. Extra care is needed in frail, elderly patient having limited mobility with arthritic changes of cervical spine, which makes difficult to turn head to facilitate passage of endoscope. Pressure and skin injuries are also common in frail and elderly patient. Post-cholecystectomy or any intervention of anterior abdominal wall may require analgesia prior to positioning.
What are the contraindication for prone position?
Patients with tense ascites, advanced pregnancy, third trimester pregnancy, severe immobilized cervical spine disease, patients with marginal cardiopulmonary status, sir, and critically ill patients with multiple intravenous lines, infusions, and ongoing treatment. These are
Okay.
related contraindications of prone position.
Okay. What are the other positions that ERCP can be done? If at all these are the contraindications for prone position, then what are the better alternatives for this?
Supine position and lateral decubitus position, sir.
Okay.
So, okay, pregnant patient, what you will do? Supine position. Okay. So, pregnant, which trimester is preferred?
Second, sir.
Whenever there is
Second
obstruction, second trimester, third trimester
Second trimester.
is a preferred. Okay. So, in pregnant patient, any extra precaution you will take for ERCP?
Yes, sir. In advanced pregnancy patients, in supine position with the left lateral tilt position to prevent the aortocaval compression, sir.
Okay. Radiation
Okay.
exposure protection, anything you will take? Because baby is also inside. No?
So lead apron sheets can be put over the abdomen to protect the fetus from the harmful rays.
Yeah.
So, what they are doing exactly? There some. This is just a obstructive thing. So what they will do? They will remove the endoscope. And they'll remove the stones, and they will decompress the hepatobiliary, pancreatico-hepatobiliary system. So what are the possible complication in this procedure? Can you enumerate?
Yes, sir. The complications of ERCP from anesthesia related in non-intubated patients, there will be a chance of loss of airway, hypoxia, hypotension, aspiration risk, conversion from MAC to general anesthesia, arrhythmias. These are the anesthesia related complications, sir. Procedure related complications, post ERCP pancreatitis, post ERCP cholangitis or cholecystitis, bowel perforations such as duodenal perforation, pancreaticobiliary perforation, hemorrhage.
Okay.
How do you treat this post ERCP pancreatitis, PEP?
Is most common complications of post ERCP, sir. It will subsides on its own in few weeks, sir.
Okay. What is the drug of choice if for this PEP? Post ERCP pancreatitis. We can use diclofenac suppository.
Diclofenac suppository.
Octreotide also has been sometimes shown to be effective, sir, post-operative pain management.
Okay. So venous air embolism, you have written as complication, venous air embolism. So can it be prevented?
Can be prevented, sir.
How can we prevent this?
So one is
So by replacing
positioning.
air by CO2.
Sure.
If you replace air by CO2, embolism will be prevented. Okay, few centers earlier were using air. Now most of them are using CO2. Okay, by that way we can prevent air embolism. Is that okay?
Yes.
Okay.
Yeah.
So, Trinatha, that bowel perforation is one venous air embolism. You said. Any chances of pneumothorax in this patient? Because few article is noted that pneumothorax is also happening in this procedure.
There is chance of pneumothorax.
Very less chance, but I think so. One or two places where my friend also there said me about the pneumothorax during this procedure. So it's even very less chance, but there is just after procedure, patient will go to hypoxia and just abnormal segment. You have to look into any pneumothorax component is there or not. Okay. So, fine.
So,
So,
Trinath,
what
can you
is
say?
Rakesh? Yeah, you can
Yeah.
continue, Rakesh. What you want to ask?
So that like
Quick.
most centers prefer doing under what like monitored anesthesia care compared to GA. Since our gastroenterologist prefers GA, we are doing it on GA. Can you just differentiate between this MAC and GA? Trinath,
So, uh,
what are the
many high volume
advantages and when do you want to do under MAC and GA?
uh, based on the procedural factors and the patient factors, the plan of anesthesia is chosen between the modern anesthesia care and general anesthesia. Sir. When it comes to the procedural factors, if it is short procedures allowing for rapid patient recovery and by the experienced anesthesiologist, only and it is if it is only diagnostic procedure without any therapeutic, and when it comes to patient factors, patients with the high risk of post-operative nausea, vomiting, low ejection function, fraction with recent myocardial infarction, hypotension patients, chronic obstructive pulmonary disease, and asthmatic patients, elderly patients, more favorable for the modern anesthesia care, sir.
Okay.
And
Good.
procedures with high gastrointestinal bleeding risk and draining of abscesses, prolonged procedures with risk of hypoventilation, perforation risk, such as pneumoperitoneum, increased abdominal pressure, gastric outlet obstruction, and patient factors with the uh, stomach and full stomach, aspirational risk, and hemodynamic compromise uh, patients more preferable for the general anesthesia.
Okay. Good. I'll ask few more MCQs related to
Wait,
this.
wait.
Yes, sir. Yes, sir. Please tell me.
Some, Dr. Ritika.
Yes, sir.
Yes. So, if suppose decompression done, okay, hepatobiliary decompression done. So, how you will assess it is a effective decompression? Anything you will see? First, the symptom will go. Okay. Any investigation part? Anything?
The ETCO2, sir.
No. That hepatobiliary pancreatic decompression we are doing. No? I'm just wanted to know about. You're knowing anything about delta bilirubin?
Delta bilirubin, sir, it's in patients with chronic liver disease and who also have concurrent renal failure. So what happens is a fraction of the bilirubin will get conjugated with albumin irreversibly, sir. So and this part of fractional bilirubin will is not, though it is not toxic, it is not getting excreted via the urine or the stools. So it will be present in the blood for long durations. So this is called as delta bilirubin. So once the primary disease is taken care of, slowly and gradually this delta bilirubin values also comes down.
No, initially it will increase. Then it will tell about the this one effective decompression done.
Effective decompression.
Okay. So in other cases like a stricture and things, they are putting stent also. So what kind of stent they're putting? Endoscopist will put stent to clear the obstruction.
Metallic stents are commonly being used.
Self-limiting metallic stent they're putting. It is common.
Self-inflating metallic stents.
Self-inflating. Okay, fine. And what if suppose there is complication, you are feeling like there is a hypoxia, fine. What are the other severe complication post-operative period? Because we are dealing, all patients are very sick. ASA3 or ASA4 patients commonly are coming for endoscopic procedure for like this obstructive biliary disease or some other. So what are very common apart from hypoxia, intraoperative hypoxia? What are intraoperative and post-operative common complication?
Aspiration risk is very common, sir.
Okay.
Apart from that, hypotension can occur.
Why hypotension is occurring?
Sir, usually when the procedure is done under monitored anesthesia care, the airway is compromised. So there is high risk of aspiration.
Aspiration is one thing. Why there is a hypotension? Because predominantly you're
Hypotension
using
is
propofol. Now, propofol has a tendency, and there's a multiple comorbidity patient that can go to the hypotension. So you need to monitor post-operatively. And hypotension sometimes can lead to cardiac arrest also. So that is important things you need to look for. Okay. Anything, Dr. Rakesh?
Yeah, I'll share a few MCQs, sir.
Yeah.
Yeah. This we are done. Contraindications for ERCP are option A, recent myocardial infarction, option B, recent MRCP, option C, patient with history of asthma, option D, all of the above. Contraindication for ERCP are the following. So most of
Recent myocardial
them are going with option D. Most of them are going with option D, all of the above. Recent MRCP is not a contraindication for ERCP. Patient with history of asthma is not a contraindication for ERCP.
Yes, correct.
So coming to answer is recent myocardial infarction because of positional discomfort and the procedural discomfort. So recent myocardial infarction is the answer. So coming to next question. Complications related to ERCP are option A, pancreatitis, option B, perforation, option C, hemorrhage, option D, all of the above. So what our audience are like answering? Just a second, Rutvik, Trinath. Yeah, all of them are going with option D. What's your answer, Rutvik and Trinath?
Sir, all of the above.
Yeah, all of these are complications of ERCP. Good. So this is a case. See, you're asked to provide sedation for 35-year-old man requiring endoscopic retrograde cholangiopancreatography, that is ERCP, in radiology department. The most appropriate statements regarding sedation for this patient are. So option A, systemic analgesia is not required normally. Use of 2 or more drugs reduces the incidence of overdose and the respiratory depression. Loss of verbal communication necessitates the same level of care as general anesthesia. Supplemental oxygen may be administered to prevent hypoventilation. And use of continuous waveform capnography to monitor adequacy of ventilation is recommended. Which is the most appropriate among this? It's a big sort of lengthy question, so we'll just give few more seconds for the audience. So what are they answering? Yeah. Pure with option E, pure with option B. Okay, most of them are answering it right. Few of them are going with option B, but what's the answer, Trinath?
So, use of continuous waveform capnography to monitor adequacy of ventilation.
Yeah, that is the most appropriate statement among these 5 statements. That is most appropriate as an anesthetist. Okay, fine. So you can share back your slides. So do you have any airway adjuncts for this ERCP? I know definitely we are doing it under GA. If you have an option to do it under some other techniques, do you have any airway adjuncts?
Yes, sir. There are recent adjuncts for the ERCP procedures processor. The first one is plain mouth guard, which is having two ports and two ways for the two ports are for the oxygen supply and capnography, and another port is for the passage of endoscope, sir. These mouth guards are used for modern anesthesia care procedures. Under gadget is VBM endoscopy masks. It is also used in modern anesthesia care procedure, where one port is for the passage of the endoscopy and another port is for the ventilation.
Okay.
The applications of endoscopic mask, fiber optic intubation, bronchoscopy, gastroenterology applications, transesophageal echocardiography.
Good. Any other
And,
adjuncts?
this is
Yeah.
gastrolaryngeal tube, sir.
Okay.
It is having it's one kind of LMS used for the modern anesthesia care in procedures. With one port is for the passage of endoscope, another port is for the ventilation, sir.
Anything else? Pranath?
LMA gastric airway, sir.
Okay. So this gastro, which generation LMA this is?
Second generation LMS, sir.
Okay. So they have a separate port for endoscopic wire, and
Yes.
the white block is this is second generation LMA. It's very good. There is no chance of damage to endoscopic camera. Okay.
Yeah, that's what most gastroenterologists are not happy with some of our airway adjuncts because of damage to their.
I want permission of Madhuri madam. Few audience is asking some questions, so
Yeah, if you are finished with the presentation, then we can deal with the questions, sir.
yeah. Time is there, no? It's 15 minutes only is left.
Yeah, around 10 minutes more.
10 minutes. No, just 2 to 3 minutes will just wind up,
Yes.
madam.
Yes.
Oh, thank you.
How do you conclude your thing, Trinath? So any evidence-based thing we have done something for that? What the practices you are doing in our institute? Any evidence for that?
Yes, sir. As per the anesthesia-related complications, in respiratory adverse event complications, modern anesthesia care increases the risk of intraoperative apnea more than general anesthesia, in particularly in COPD and asthmatic patients, sir. And when it comes to cardiovascular adverse events, the modern anesthesia care is preferred over the general anesthesia in patients with recent diagnosis of myocardial infarction and severe heart failure. As procedure related, general anesthesia is preferred in procedures that carry an increased complication risk, uh, such as aspirational or bleeding, endoscopic ultrasound guided transluminal access drainage, ERCP with concurrent gastric outlet obstruction, prolonged cases with high procedural complexity and massive post sphincterotomy bleeding. Prefers general anesthesia over the modern anesthesia care.
You're telling in summary, like complicated cases we want to do under G where you expect complications. Okay.
Okay, Dr. Rakesh, I would like to answer a few questions asked by Rajesh.
Yes, sir.
Their questions are why there is a pneumothorax in ERCP surgery. There is no any correlation, but pneumothorax is noted in few articles is there in favor of that. So some this center has mentioned it's a bilateral pneumothorax, but there is a very few chances, very minimal chances of pneumothorax is there. And other common complication is more common than pneumothorax is air embolism. Okay. And you ask about the question of delta bilirubin. So delta bilirubin, what is happening? No, when there is obstruction, conjugated bilirubin is in hepatobiliary tract only. Once there is decompression, it will come down to and absorb, and it will get bind to the albumin. When bilirubin will get bind to the albumin, then suddenly delta bilirubin amount will increase. So you will get increase in delta bilirubin. So after decompression, that is a sign of right decompression, correct decompression. And one more question asked by some audience. I'm feeling that this gastric decompression also. In case of gastric obstruction, so endoscopy can be used as a gastric decompression also. So, any other questions?
One more question is there, sir. Like they were asking, like effect of fentanyl on sphincter 40. Is pentozocin better than fentanyl? Yeah, definitely coming to opioids, morphine has highest and fentanyl has the least. So definitely taking into consideration of all other aspects, we use fentanyl. Definitely pentozocin is an option we would have used, but fentanyl is better. It has least effect on sphincter 40 compared to morphine.
Yeah. So other newer drugs also is in picture, like remimazole, Zolam, and ramifentanil, alfentanil, which has very less effect on sphincter body, has a role. But we are not frequently using in our center, so we cannot comment more properly on that. So, but fentanyl we are using, and endoscopist is quite comfortable with that. They are not finding any difficulties of that kind of a spasm. So done with the discussion, Dr.
One more question is there, sir. Which drug is better for deep anesthesia during ERCP? So I think ketamine, propofol, and dexmet combinations are better, no, for deep under monitor anesthesia care. We can take use of dexmet. It's a better alternative for arousal sedation.
Yeah, preferred propofol is there, because target control anesthesia because we are not using, but whenever target control role is coming, their propofol is much better. And ketamine, if you will use with a propofol, that is better control of spontaneous airway as compared to only sole propofol. And dexmed also is.
One question is there, sir, LMA gastro, how frequently it can be used? So again, it depends between anesthetist and gastroenterologist, how compatible with the things and duration of the procedure. We can choose an LMA.
Yeah, correct.
Yeah, I think, ma'am, we have answered most of the questions.
So there are a few unanswered questions. One is, what is the any special considerations for liver transplant patients?
Apart from the drug modification, there are no much considerations, like apart from the dose of the drug modifications and the extent of disease in that patient, depending upon the blood investigations, we can alter the concentration of the drugs that we use, or else nothing else.
We need to be more vigilant about the post-op complication that kind of patient. That will be always SA3 or SA4 patients. So that we have to. Otherwise, drug-wise, I'm not feeling much differences there.
If it's only diagnostic, we can go for MRCP. It's only therapeutic, then we'll go for ERCP in this patient.
Okay. So also for any given total hyperbilirubemia, amongst conjugated and unconjugated hyperbilirubemia, which one is the highest anesthetic consideration?
So first way is question. I'll read it out again. Wait, I'm just going through the question actually.
Okay.
For any given total hyperbilirubinemia, among conjugated and unconjugated hyperbilirubinemia, which one is of highest anesthetic consideration? Definitely the conjugated will be of highest consideration.
Conjugated in findings, but conjugated will tell about some problem in liver. So reduction of dose of anesthetic drugs will take more priority of reduction and precise dosing of anesthetic agent in unconjugated hyperbilirubinemia as compared to conjugated hyperbilirubinemia.
And again, as like we discussed, conjugated biles or salts and bile pigments will decrease the contractility of the heart and there'll be hypotension post anesthesia. So conjugated and is more important compared to
Wow.
unconjugated bilirubin.
Also, sir, this question was asked in the beginning that why diclofenac was used in a 65-year-old.
It does
Yeah.
not have any comorbidities as such, and our institution gastroenterologist prefers diclofenac because he has seen many case reports of post ERCP pancreatitis, and diclofenac was a drug of choice for this post ERCP pancreatitis. He prefers it actually.
Okay, sir. Okay. I think, so most of the
That,
questions in the chat box have been covered.
yeah.
I'll hand it over to Dr. Madhuri.
Yeah.
Thank you.
Thank you. Thank you, Dr. Srinath and Dr. Rakesh, Dr. Shailesh for that excellent presentation on ERCP. So, just one question from me. Dr. Srinath, you said that when you took the patient's history, no, you said that you asked for the history of urine output, right? Unmute yourself.
Yes, ma'am.
Yes. So I think Dr. Rakesh asked you that why. So you said that was to rule out the hepatorenal syndrome, right?
Yes, ma'am.
Yes. So tell me, what are the criteria to diagnose it as a hepatorenal syndrome?
It is basically a exclusion criteria, ma'am. So
Excellent. Yes, it is a diagnosis of exclusion. Yes. What
so
else?
patient should not have any underlying disease or
Yes.
any renal identifiable cause.
Yes. There should not be any structural injury to the kidneys. Okay. What else? But there should be a diagnosis of liver disease like cirrhosis with ascites.
This with ascites and
That should
the
be there.
creatinine level must be raised now.
Yes,
And
creatinine should
patient
be more
should not
than
be in shock.
1.5. Then
Then there should
even
be
if you,
absence of shock and hypovolemia.
yes, and even if
And
you give
absence of
diuretics,
using
there
the
should not be any improvement. Anything else?
improvement. And patient should not be on any nephrotoxic drugs.
Yes.
And there shouldn't be diagnosed of any renal parenchymal disease.
Yes, renal parent. That's what I said. There should not be any structural kidney injury. Correct. So unless you ask all this, without confirming this, you cannot say that it is hepatorenal syndrome. Okay, good.
I just want to ask one thing. That the question was very important, the conjugated and unconjugated bilirubin for anesthesia purpose. What is basically we're going to give anesthesia, you're going to give GA, how your drugs are cleared, how your drugs are metabolized. Conjugation level does not affect anesthesia. It's unconjugated because that signifies the liver dysfunction. The more unconjugated liver is there, that means the liver is not able to metabolize the bilirubin, and that means the liver dysfunction is there. The plasma protein levels are different. Liver is not going to metabolize the drugs. Anesthesia drugs will be of higher level. There you have to reduce the dose in those patients. And because unconjugated bilirubin, again, you have got all the multiple systemic problems also. So it's not the conjugated, it's the unconjugated level which will have impact upon anesthesia practice, not the conjugated. I have just to rectify that statement.
Thank you, sir.
Thank you, sir.
Ashita, Sally, any other question left? Something?
Sir, yes, there's one more. They asked about the distension of abdomen post-operatively, how to deal with it.
Yeah,
We
yeah.
can-
Yeah, that question I have just missed. Actually, distension is happening. We need to rule out either it is a procedural perforations. At least we will do ultrasound and then we'll just see the perforation is there. We have to rule out that one. Post-procedural perforation, pneumoperitoneum. And that way we can just, if it is not, then it's not a problem.
Yeah, because even if the patient is having liver disease, ascites is not going to get accumulated immediately. Either it's one is the perforation, then the paralytic ileus also, if the distension is there, it takes a lot of time. So mainly it is the mechanical, injury, iatrogenic injury during the procedure. That should be always, I think, given the best investigation to go further. It can be an emergency also, basically.
Yeah.
So any other question, Ashita?
I think, sir, no other question we're done. Probably
Okay.
everything else was covered
Everything
in
is covered. Yes.
Okay. Let me see now, Trinath Reddy and Ritvik. So you people are taking the patient to the this one ERCP room in the radiology suite. Going for the first time. As a PG student, you have given duty as a third year, go for the first time. So what are you going to inspect there? You just make a checklist. What are you going to inspect there in the radiology suite? You have to give a sedation oblique GA for ERCP. No, that is very, very important. That is a question going to be asked in your external examination also.
The first thing I would like to keep my emergency crash cart ready. So if there
You will
is an
take the
airway
crash card ready
complication,
means you have to take the crash card along with you from the department. You don't expect a radiology suit will be having a crash cart for you. The drugs, the equipment will not be available in the radiology suite unless and until the institutional protocols are at place. In spite of that, even if it's there, you still carry a crash cart with you whenever you are going to radiology sort of your because you may not be knowing somebody may have misplaced the equipment or drugs from their different cart. You may have something in place or a dedicated technician is there for these procedures who can take care of this equipment and drugs there. So you have to carry your own crash cart, a smaller one maybe, from your department to this radiology suit, in spite of it may be having or not. Okay, now what are the things which are important there?
oxygen source,
Mhm.
basic standard monitors, crash cart,
So I am then is the MRCP. Okay, your MRCP and ERCP you are talking about. In MRCP, how are you going to the compatibility, the compatible equipment? That is
equipments for
very,
MRC.
very important. You should be knowing your radiology suit, whether they are compatible with the MRIs or something like that, if you are going to do for the diagnostic purpose even. Because oxygen source, the patient is on having some difficulty problem, you want to give oxygen only. Or even if you are going to give sedation rather to a normal patient, going into the hypoventilation or a ventilated drive failure occurs. So for that also you have to have a compatible oxygen source. Do you know anything how you can make it compatible?
Your MRI compatible oxygen cylinders,
Are they,
molybdenum.
have you seen any?
We use MRI compatible oxygen cylinders in our MRI suites. So if patient needs any sedation, so oxygen, we give sedation and
Equipment,
with oxygen support.
monitoring equipment, which is should be compatible, the monitoring
Compatible with
equipment.
MRI.
So these are little challenges. So whenever you are faced with that thing, one thing is that even every center may not be having the oxygen compatible cylinders and equipment gadgets which may be compatible with those things. So whenever you are taking this patient, you are going as a third year resident. Invariably, third year or something, you may be accompanied by a senior resident or assistant professor to that suite. You should be taking your every bit of drug, especially you should be prepared for a airway securing. That is very, very important because the worst part is the airway securing there in those suits. That is going to give you the most horrific times. Everything goes well, it's fine, and 99% it may go well, but the airway management is the most important part in the this one radiology suits, and how you monitor their respiration and how you are going to. The technical assistant must be there. As a doctor alone, you cannot help. You must take a one technical assistant who will help you in taking out all the emergency, equipment and drugs. Because as a doctor, you may not be, sometimes you may panic, but these technical assistants are very good people to have with you. They don't panic. They always try to help you in the best way. So be prepared for the airway management in these cases, and airway management means the equipment which is well versed, which is very well compatible with these suits. So make a checklist. The idea is to have a checklist. You say, we will carry a checklist, we will see, mark the checklist, because this is not an emergency procedure. It is maybe a semi-emergency or elective procedure. So, but you mark a checklist with the ticks. That is very, very important part. Fine. Anyway, you answered well, almost everything you answered today. That was a good thing. Third year and second year, the confidence was oozing, and in a very genuine manner you were answering. Things were good. Let's see if some people want to ask you something more. Don't worry, I'm with you here to answer for you also. Dr. Mohan Pathak, sir, he wants to ask. Just wait, sir. Just wait. I will unmute you, sir. Just wait. You can unmute yourself. Mohan, sir.
Now, sir, prone position is very demanding. So mostly we do in the lateral position, alternately in between supine. So that will be easier thing. Secondly, the air distension happens always, and it takes its own time because we know where they are constantly putting air inside. Thirdly, the PTBD, sometimes ERCP goes fail. You cannot do anything. You cannot pass a guide wire nor the abnormal things and all. So PTBD can be done. That is the same sitting when the another specialist you need for the percutaneous drainage of the biliary from the biliary radicals and all. That much I want to say.
Majority of the,
PTBD.
sir, I think it depends upon the experience and
Yeah.
you know, that learning curve of a gastroenterologist also, how they're going to do it, whether they are doing it in the semi-prone position or in the lateral position, because the level of comfort with their skills, how they're handling their endoscopes, that is a very, very important part. And some feel very comfortable with the prone. And I think when we are going to the radiology suite, we should be well prepared for all type of positioning.
All type of anesthesia.
Yeah, whether it's a
Yes.
lateral or a semi-lateral or it's a prone position, whatever it is. So we should be well aware of all the positioning and the complications associated with those positioning. So it
Yes,
depends. As a good gastroenterologist, he will make your life easier. You know, he will not trouble you. But majority of them are in the learning phase. You know, the fresh past DM, they're coming there. They are more enthusiastic in doing those procedures, and they are not aware of these type of complications happening. Because when they are doing the
Yes.
DM during their courses, the people used to give anesthesia, the senior people, they always manage. But in some institution, if the third year PG is going, I think the third year PG is good enough to carry all the procedures. But the other side of the story, that means the gastroenterologist, he can be the little bit of a culprit in giving us more complications on those days. So I think it will be a lucky day or unlucky day. That depends upon the level of skills of that gastroenterologist also.
Yes, sir. Thank you.
Anybody else want to ask? Our PG students are there. You have to give them passing marks today. Otherwise, you know, they have done such a hard work. And it's a, you know, in the beginning, I told ERCP is such a procedure. It looks easy, but it is the most challenging. The NORA is the most challenging. I think Dr. Ridhima is also doing almost every day nowadays. Her posting is in the NORA only. So you can also comment upon those things.
Yes, sir. I think definitely, as you said, the equipment should be checked. That is paramount, and you should be prepared with your emergency drugs so that any time of crisis and call for help is very important. That we usually forward, and it's very paramount to check. Equipment checking is very important. I feel that, and if you're not comfortable with certain procedures, you should not go ahead. You should be very clear about what you about your limitations and all the things to go ahead.
Yeah, that's a very good point. If you are not sure whether you will be able to do the procedure, you call a senior. You call a senior rather than just going ahead with something and getting entangled or trapped into a complicated scenario. It's always better to call a senior. Dr. Lalit sir want to say something. Lalit sir. Lalit sir was here only. I think he disconnected.
I am here, sir.
Yeah, sir, please ask.
Good evening, sir.
Good evening, sir. Good evening.
Just regarding the oxygen cylinder, if we are not having most of setup not having the compatible cylinders,
Well,
what we can do, we can use a long extension tube
yes, I was
for
going to
bell
come to that.
circuit as well as the polymask. That is a
Yeah.
simple answer. And regarding the to take care of the hypodermic needles, because we have to give continuous anesthesia, maybe loading dose frequently. So what we can do, instead of using hypodermic needle, we can use our cannula. The ampules are open. We have to pour the drugs through that cannula. That is outer sheath, not the metallic inner one, outer one. So that can be a solution. MRI compatible.
Yeah.
So we can
Yesterday
withdraw drugs by that cannula outer sheath, as well as we can put that cannula in the vials also, wide bore. That easier that we can able to withdraw multiple drugs. This is my submission.
Yeah, this is definitely because everything is not written in the textbook.
Yes,
So
sir.
you can have a long extension of the oxygen tubing. You can use that the needle cap as a connecting link between the two pipes, two oxygen pipes. You can elongate them like anything. They snugly fit into that, and with that you can always deliver the oxygen from outside the door also. That is one way, because this you won't get a mention in the textbook, but the tropical countries, the developing countries, are those countries which have got a very innovative and brainy minds. They go with these type of things. You don't require the standard textbook material to be taken into these compatible and the non-compatible radiology suits. Similarly, with the way we use the extension tubing for the IV lines.
Yes, sir.
Suppose IV lines. So same thing can be done, whether the three-way you are put a three-way between all the different lines. We can use all these extension tubings.
Or
That
we
is
can
one way.
use the distal end of the IV drip that is connected with rubber one. That connection can be fit in the continuation.
Yeah, that is, I think, same size, sir.
Yes, sir. Same size. That's right.
Tip of the this one infusion tip, as well as that the needle cap also. Just cut it from the blind end. It will become a continuity for the tubing. So those can be done in the as a jugaad, whatever you call it.
Yes, sir.
But
Yes, sir.
I think these should come into the textbooks of also. But I don't know, the Britishers have a hold over, the Americans have a hold over these textbooks. They will allow these type of things to come up or not. But these are the real practical things which are helping in different Asian countries, African countries. So these are the real materials. They should come into
the silicone ambu bag, laterally, that should be always available, and if possible, the plastic laryngoscope that is MRI compatible.
Sir, if we have this silicone bag, we are able to purchase. I think we will able to purchase the tubings also. We can tell the manufacturers to manufacture the long tubings also.
Yeah,
that is
no. Laterally, that is available almost everywhere nowadays. Silicone is
nice,
cheaper.
I think if the institution has a capacity to buy those things, so they can buy the long tubings also, rather than resorting to those type of things. Yeah, that's true, sir.
Thank you, sir.
Thank you, sir. Thank you very much. And I think, just wait, sir. It's time for actually to felicitate the people here. They've done a wonderful work. Just let me see. Is the screen visible?
Yes.
Dr. Madhuri, is visible?
Yes, sir. It's
Yes,
visible.
sir. Yes, sir.
Clearly visible.
Yeah. So we are really thankful to the team. They present one of the most complicated scenarios. It looks so simple, but it's so, see the length of discussion and the questions. So we are thankful Dr. Utkala Hegde madam and her team. She is the professor and head, and she has guided the team to a very good discussion in this class. Thank you, madam, for being the leader of this class.
Thank you, sir.
And Dr. Shailesh, I think he was very much, I think his attitude was so good that even the PGs were not able to answer, so he was there anyway to postpone the question and took it to the next level. So I think that's the way how the PG should be taught in the classes. Thank you, Dr. Shailesh.
Thank you, sir. Thank you, sir.
And Dr. Rakesh, you are a dynamic young assistant professor doing good job. And I think you must have done a lot of hard work on the PG students. I think that's why they were so confident. And it was oozing from the conversation between you and them. Thank you, Dr. Rakesh, for being a faculty in this.
Thank you so much, sir.
And Rutvik, yourself as a third year and then Atrina as a second year. Thank you very much for a good PG students. I think you have passed your pre-final. So Dr. Utkala will be giving you grace marks when you are appearing for the finals. So we, as a team of ISA, we also put Safarish to madam to give you good marks during your final examination. And Ashita, thank you for being a screen coordinator for this thing. You
Thank
did
you,
a
sir.
wonderful job, as Siley also. She all in despite
you,
her
పెట్టండి
disabilities.
ఇది బాగానే అయిపోయిందమ్మా.
So thank you everyone for being this part, and thank you Dr. Madhuri, Dr. Ridhima, Dr. Nishant. They are always the class coordinators. They teach everything. They coordinate with everyone to take the class to the next level. I think in the coming times we will be having, as in the beginning told, we were going to have the webinars, international webinars now very soon. We are going to collaborate with the other countries like US, UK, South Korea, and all those things. So we will be interacting with the PG students from all over the globe now. That is the, I think this year that we have got that set the parameters right for taking this class to the next level. Thank you very much. I think anybody want to say, Madam Utkala, Madam, you want to say something?
Yes, sir. Yes, sir. I would like to take this opportunity to thank ISA National Governing Council and Dr. Sukhminder Jeet Singh Bajwa, sir, Honorary Secretary ISA National, for giving us a chance to present a case on anesthetic consideration ERCP procedure and your support, sir, in conducting this session. Thank you again, sir.
Thank you, ma'am. Thank you very much. It's a privilege to have people like you on this class, and it will be available on the YouTube. So our PG students will be watched, the faculty will be watched by the other postgraduates from entire country over the time. I think whosoever will be appearing for the examination, this question can come as a short question or as a short case also during the examination. It is going to be very important. Almost every question is covered, and nobody can ask a question outside from this preview. So the paper is leaked. So best wishes to all postgraduates.
We'll definitely ask this question to postgraduates. Sort this in case.
Yeah, definitely.
Thank you.
Thank you so much. Thanks, sir. Thanks, Madhuri madam. Thanks all audience for giving a nice question. Thank you all. Thanks. Thank you so much.
So good night and see you next week at the same time, 6:30 p.m. Till then, I think we will be hoping for a next good class to come up. So good night and long live ISA.
Good night. Bye, sir.
Long live ISA.